So I want to acknowledge on this beautiful sunny day after a week of not so sunny that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland, and all of you, wherever you are in this province or anywhere else on this land, are also respecting elders past, present, and future, and the land on which they come. And we dedicate to learn more about where we come from and the people around us on a daily basis. So thank you. And with that, I'd like to introduce Dr. David Collister. David completed his MD at the University of Manitoba, his internal medicine residency at the University of Alberta, a nephrology fellowship at the University of Manitoba, and his PhD in health research methodology at McMaster. He was a Crescent Fellow and is now a Crescent New Investigator. And he's garnered multiple CIHR awards, which is, for those of you that know, not so easy early on in your career. So congratulations to David for that success. And he's really been an advocate of patient-centeredness and focusing on specifically initially symptom management in patients and kidney disease, and currently interested in and sharing with us insights into transgender, non-binary, and gender diverse populations in kidney disease. So David, thank you. You're now based at the University of Alberta, so in Edmonton, so only an hour away. So congratulations on that position, and we're looking forward to your talk. Thanks.
Thanks so much, Adira. So thanks for the introduction, Adira. I'm David Collister. My pronouns are he, him, his, and I'm coming from University of Alberta in Edmonton, so that's from Treaty 6 territory. And I'll be talking about kidney disease in the transgender, non-binary, or gender diverse person. So I'm going to start with a case just to frame the presentation. So this is an example of a 65-year-old transgender man who's seen in CKD clinic that has a baseline creatinine of 150, whose gender identity is a man. If you put in the eGFR into the CKD epi updated equation from 2021, it spits out 41.5 mils per minute. With a urine ACR of 50, if you do a 2 and 5 year KFRE, you get around 3% and 8%. So depending what variable you put into the sex or gender part of the eGFR equation or KFRE, this is before they start gender affirming hormone therapy, you can get some variability in their eGFR, so a difference of almost 10 if you put in female or woman for sex or gender in this particular case, with KFREs that are almost double in this scenario. As you take care of this patient over the next 12 months, they start gender affirming hormone therapy with testosterone. Their weight goes up 4 kilograms. Their creatinine increases around 14 micromoles. And there's a resulting change of a drop in GFR around 4 to 5, depending on, again, what the sex and gender input for the eGFR is. And the KFRE also changes over time. But the big question is that change in creatinine related to the muscle mass that we know changes with gender affirming hormone therapy, and what is the degree of precision and accuracy in these risk prediction in the setting of a transgender patient. So a lot of uncertainty and questions about what to do with these. So objectives that I'm going to talk about today are defining and distinguishing between sex and gender, and going over some terminologies just to make sure that we're on the same page. We're going to review the impact of sex and gender on outcomes for kidney disease, and then review the medical care of transgender, non-binary, and gender diverse persons as an overview, and then dive into issues about the care of transgender, binary, non-binary, and gender diverse persons from a nephrology perspective. So distinguishing sex and gender is important. So sex is a biological construct, and it focuses on chromosomes, genetics, proteins, anatomy, sex hormones, and physiology. And there's 3 distinct categories. So that's female, male, and intersex. Gender is a different construct that is culturally defined, and it's how one views oneself or their identity. So it's viewed through culturally defined roles, attributes, social characteristics, and expressions. So there's gender identity, there's gender expression, which is how you express that gender identity. So what you wear, what your hair looks like, kind of accessories, different types of behaviors. And categories include woman or a girl, man or a boy, and then non-binary, genderqueer, agender, bigender, two-spirit, and multiple other categories. So it can exist along a spectrum. So within gender, there's cisgender, which is a person whose gender identity aligns with that of their sex assigned at birth, and that's an adjective. And then transgender is a person whose gender identity does not align with that assigned at birth, and also an adjective. You can further characterize gender identity into transgender men or women. So depending if they identify as a man or a woman, that is not congruent with their sex assigned at birth. And there's other terms like transmasculine and transfeminine that are also adjectives that define a spectrum along a gender identity as either being male or female. And then transgender, non-binary, and gender diverse is a very inclusive term that encompasses a lot of the different things that I just talked about. So it's important to, whenever you're doing any type of research or engagement, to make sure that you know if you're talking about sex or gender, because they have different meanings, constructs, and are important about risk factors and outcomes in kidney disease and general health. So we're going to jump to the next objective, which is reviewing the impact of sex and gender and outcomes in kidney disease. And this is pretty challenging because in the majority of studies, there's not necessarily a distinguishment between sex and gender. There's the assumption that when reporting any type of sex and gender research in CKD or dialysis, that it's congruent, and we're really focused on cis populations and comparing cis men versus cis women. But I'll show you what the evidence shows about outcomes in CKD and dialysis and acute kidney injury. So this is the first study. So it's a meta-analysis of acute kidney injury, looking at all types of cohorts, so observational studies using any definition of AKI, so either in hospital or hospital acquired, using a KIN criteria, KDIGO criteria, other criteria, and looked about the adjusted sex stratified results for AKI in different patient populations, including non-cardiac surgery, cardiac surgery, and other settings. And what it showed was the risk of AKI for men versus women was higher. So the odds ratio of 1.2 with a 95% confidence interval of 1.1 to 1.136. And this was consistent across all the subtypes except for cardiac surgery, which were smaller cohorts. So one of the issues about acute kidney injury is definitions use absolute or relative rises in serum creatinine. And women, we know, make less creatinine because they have a smaller muscle mass. We adjust eGFR calculators for that. So there's a concern that AKI in women might be underdiagnosed, less treated, less opportunities for referral for dialysis, or late referral for dialysis based on complications, poor follow-up, et cetera. And this is an active area of research in the AKI world. Nish Panu here out in Edmonton is investigating sex-specific thresholds to diagnose AKI, which is very interesting. From a CKD perspective, there's a couple meta-analysis. They're kind of over 20 years old at this point. This is another one by Newgarden that looked at cohorts, including chronic kidney disease and different subtypes in observational studies, and a consistent signal across subtypes of CKD that the rates of progression are higher in men versus women. So this is a Cohen's statistic showing that it's increased in men compared to women. So this is in all types of chronic kidney disease. They looked at specific subtypes in this one. So membranous nephropathy, IgA nephropathy also have faster rates of progression, as well as to dialysis compared in men versus women, with actually the opposite seen in polycystic kidney disease. So potential, is it sex hormones? Is it gender or identity and gender behavior around healthcare interactions, adherence, and stuff like that? We don't know. So this is another systematic review that looked at CKD progression by Jafar. It looked at 11 trials of ACE inhibition in non-proteinuric CKD and looked at sex and gender as a risk factor. It was multivariate analysis looking at different types of covariates, so demographics, age, co-intervention, stuff like that. And it showed that the increased risk of CKD progression was again higher in men versus women, defined as doubling of creatinine or dialysis or just dialysis on its own. So the most recent studies that look at this are actually from the CKD Prognosis Consortium, which includes Canadian cohorts. So this is a study from 2013 that looked at sex-specific hazard ratios for mortality as well as risk of kidney failure, which I'll show on the next slide. In the green versus red-orange on this slide for adjusted, so for covariates, same thing, demographics, comorbidities, medications, other interventions. Men had a specifically higher risk of mortality across EGFRs. So an example at the mean cohort, this is in all the high cardiovascular risk, non-CKD and CKD populations. It was 1.60 for the adjusted hazard ratio of men versus women. And when they looked at linear splines over time, there was evidence of an interaction. So the risk of mortality varied by EGFR in men versus women. So it actually was higher in lower GFRs in women than in men. So that's figure 2 here, showing that the risk crosses. When they looked at albuminuria, same thing, higher risk by albuminuria status for mortality. We'll talk a bit about interpreting albuminuria in the setting of sex for 24-hour urines and risk. Same thing, that there was an interaction by sex. So this is for the outcomes of mortality. When they looked at the risks for dialysis, so it confirmed that lower EGFR and higher ACR are both risk factors for needing dialysis or transplant in both sexes. It showed that the associations for EGFR and the risk of dialysis overlapped in men versus women. So there wasn't evidence of sex interaction in this one, which is different from what I just showed you before. But specifically for proteinuria across the range of 15 to 350, and that's in milligrams per grams, women had a higher, steeper risk relationship than men versus women. So the slope down here is higher. So there was evidence of interaction as well. So higher risk, so adjusted hazard ratio of 1.63 versus 1.33 in women versus men. So there's differences in CKD progression, risk and mortality in men versus women. And this is the largest cohort and a meta-analysis that currently exists. If you look at specifically kidney transplant and dialysis, so kidney failure mortality, this is a study this year from BMJ looking at Australia and New Zealand data over the last 15 years or so. And it looked at categories of death and causes of death, categorized into cardiovascular disease, kidney disease, respiratory, GI disease, et cetera. And across different age spectrums, males consistently had higher proportion of cancer and cardiovascular deaths related to women who had higher proportion of chronic kidney disease and GI deaths. And what they looked at was over mortality rates and standardized mortality rates compared to the general population, about if there were differences in mortality by sex/gender. So up here, mortality rate by age, just crude, was similar between men and women. But when you looked at standardized mortality rate, realizing that women generally live longer than men, there was differences in standardized ratios across age groups, and younger women under the age of 35 or under the age of 50 have the most potential years lost related to mortality and dialysis. When they looked at mortality over time, up in the top right, looked like it was potentially narrowing from 1988 over 2018, but the standardized mortality was always higher in female versus males. And then their causes of death from a standardized rate as well seem to be higher in women across all categories. So there's a gap here and we don't know why necessarily. So what do we know about some of the sex hormones from an endogenous perspective? So there's a couple studies related to animal models and human cohorts that I'll go over, looking at sex hormones, and specifically we'll focus on contraception first. So we know that estrogen and progesterone as oral contraceptive pills activate the renin-angiotensin-aldosterone system. It increases blood pressure in the general population up to a systolic of 8 and a diastolic of 6. It is associated with microalbuminuria and as well as albuminuria development in diabetes specifically. When you look at combined patches, which don't have first pass metabolism, looks like they potentially lower the activation of the renin-angiotensin-aldosterone system, and it blunts the response to any orthostatic change or stress. Progesterone as a single agent also upregulates RAS as well. So there's some influence on interactions between sex hormones from a female perspective and some of these kidney hormones. Specifically for hormone replacement therapy in patients with CKD, so Sophia Ahmed and her group have done a systematic review looking at cardiovascular outcomes and surrogates in the setting of CKD. And similar to the general population, hormone replacement therapy decreases LDL, increases HDL, increases total cholesterol, but doesn't affect triglycerides or blood pressures. And there are no studies looking at long-term major adverse cardiac events or CV mortalities, and they did this about 5 years ago. Another group looked at proteinuria as a result of hormone replacement therapy and showed that albuminuria seems to be decreased as well as proteinuria, but there are only 3 RCTs and high risk of bias. So Sophia Ahmed did a study too looking at hormone replacement therapy in Alberta across CKD patients, looking at progression of eGFR decline, and categorized people based on their prescriptions into estrogen only, progesterone only, or combination pills. So it was this cohort at around 4,400 patients, and they looked at a decline in eGFR and change by type and route of hormone replacement therapy. So it showed that compared to no hormone replacement therapy with matching based on age and different covariates adjusted for eGFR at baseline, diabetes, and other comorbidity, that estrogen use increased the risk of eGFR decline. When they looked at the type of route, looks like this was mostly oral potentially related, even though it wasn't significant for the other routes, but there were smaller numbers as well, and that may be related to that first pass effect by the liver. Other groups have also looked at long-term effects of hormone replacement therapy. So this is the Rancho Bernardo study, and it looked at baseline and 10-year follow-up of postmenopausal estrogen use in a large cohort of women between 1992 and 1996, with follow-up from 2002 to 2005. And in the top left, it looked at categorized individuals into never users, past users, or current users. And there was about 450 people in the cohort, showed no difference in eGFR by MDRD equation at baseline and follow-up. For proteinuria, it showed that there was a significant increase in patients that were current users for the whole cohort. So that's the solid line here. And then for blood pressure and diastolic blood pressure, no significant change. Even there was a trend towards significance with p-values close to 0.05. So just potentially related to smaller sample size in this cohort. What do we know about testosterone in CKD and dialysis? So we know CKD and dialysis are associated with a hypogonadotropic hypogonadism. So our patients commonly have low testosterone, and specifically in CKD and dialysis, there's been lots of different studies, some even done here in Alberta with Immunobelu, about increased mortality risk in CKD as well as dialysis, and then poor physical function, frailty, muscle wasting, as well as cardiovascular risk. So there's a signal here. In androgen deprivation therapy, so looking at even an iatrogenic form, so this is looking at UK data from large observational databases about the care of patients with prostate cancer undergoing androgen deprivation therapy. So they looked at different types of androgen deprivation therapy. So either combination androgen blockade, estrogen, other combinations, GnRH agonists, and surgical approaches, and did a case control study looking at the risk of AKI, adjusted for a whole bunch of covariates related to CKD, dialysis risk, as well as cancer care, things like surgery, chemotherapy, stuff like that, with a whole bunch of sensitivity analysis to rule out different types of AKI like obstruction or other complications and hospitalizations. And they showed that adjusted odds ratios for androgen deprivation therapy versus none shows that it increases the risk of AKI. So there's a signal that in another disease state that's different from CKD, that having low testosterone increases the risk of AKI, with questions about mechanisms as well. So we're going to switch gears to the review of medical care for transgender, non-binary, and gender diverse persons. So talking a bit about the epidemiology, the prevalence of transgender individuals in a population really depends on how you define transgender and if it's classified by self-report, the use of gender-affirming care, so either hormones or surgery. But on average, it's about 0.5% of the population, and even higher for gender diverse populations. So in most recent Canadian census, in some areas, it may be as high as 10%. There's a large study called the Behavioral Risk Factor Surveillance System. So that was over 500,000 respondents from the United States, that about 0.24% identified as transgender women, 0.14 as transgender men, and then 0.10 as gender nonconforming. So extrapolating those results to the United States alone, there's about 1 million transgender persons and then 25 million worldwide. But there's really heterogeneity depending on where you live and how you classify gender from a scientific and cultural perspective. The medical care of transgender, non-binary, and gender diverse persons is complicated. A lot of patients have experienced stigma, discrimination, and mistreatment in their own personal lives, as well as interacting with the healthcare system. And that's negatively impacted their social determinants of health, and that's led to health inequities. So there's issues about employment, discrimination, job security, income inequity, homelessness, social isolation, and this is translated into barriers accessing and maintaining healthcare needs. So the higher rates of mental health issues, as well as use of mental health services, issues about malignancy screening, so cervical, breast, and anal cancer, sexually transmitted infections, cardiovascular risk, as well as vaccination. So there's a need for inclusive, safe primary care and subspecialty care, including nephrology. When you look at health services use and conditions, this is ICS data from 2020. They published a study in JAMA looking at transgender versus cisgender populations matched on age and socioeconomic status and other factors to look at their different health services use and comorbidities over a time period and their overall ER visits and healthcare utilizations to subspecialists. So transgender individuals compared to cisgender individuals had a lower SES, higher rates of asthma, diabetes, COPD, HIV, and a lot more primary and subspecialty healthcare visits, specifically related to mental health, psychiatry, endocrinology, which is not surprising based on gender affirming care, as well as hospitalizations for mental health and emergency room visits for mental health. So the question is this related to access to healthcare and safe, inclusive care? Is it comorbidities? There's lots of things that are potentially playing a role here. So speaking of gender affirming hormone therapy, so in Ontario, about 40% of the transgender population is undergoing treatment with gender affirming hormone therapy. And the primary goal is to induce physical changes to match a patient's gender identity. And this is very specific to an individual. And the fundamental principle is to maintain physiologic hormone levels for that target gender, but considering comorbidities and cardiovascular risk and malignancy risks. So gender affirming hormone therapy improves quality of life and psychological outcomes, as well as sexual function. And there's meta-analysis that show that. In transmasculine individuals, the typical goal is to stop menstruation and induce virilization with secondary sex characteristics, which I'll go over in a second. But there's potential complications like erythrocytosis, vaginal bleeding, and hypertriglyceridemia, as well as infertility. In trans feminine individuals, the typical goal is to reduce facial and body hair, redistribute fat and muscle, and induce breast formation. There's lots of different routes of estrogen that can be used to achieve this, as well as androgen blockade, but the potential harms are related to estrogen include venous thromboembolism, malignancy, lipids, and cardiovascular disease. So these are just a couple tables from the Journal of Clinical Epidemiology and Guidelines about Gender Affirming Care from 2017. It just shows you what typical doses of estrogen and the fact that there's oral, transdermal, or injectable options, as well as these are used in combination with an anti-androgen, so something to block the effects of testosterone. And the most common, especially in Canada and North America, is spironolactone, but these are at pretty high doses that we don't typically see as nephrologists in advanced CKD or dialysis. Second-line options are all cyproterone acetate and sometimes GnRH agonists, but these are more common in children. For transgender males, testosterone can be used as gels or patches or injectable as well. So these are just some of the masculinizing and feminizing effects of gender affirming hormone therapy and their timelines. I'm not going to go over them in detail, but one thing to mention is the onset for some of these can be within 1 to 3 to 6 months, with a full effect generally at anywhere between 1 to 2 years or even potentially longer. When endocrinologists or family physicians, and depending on where you work and care delivery models, the vast majority of gender affirming hormone therapy is actually by family physicians, with endocrinologists seeing more complex cases in the setting of comorbidities. Typical management when starting gender affirming hormone therapy is, at least for transgender males, to follow up every 3 months and to follow for signs of virilization and adverse effects. So depending on what type of testosterone you use, serum testosterone levels are measured about every 3 months until they're in the normal physiologic range, but the target is related to the specific agent that you're using and their pharmacokinetics and the timing of the collection. Because of that risk of erythrocytosis, hemoglobin and hematocrit are measured every 3 months, and then beyond that, 1 to 2 times per year, as well as monitoring for blood pressure, lipids, and cardiovascular risk overall. There's some other things too about osteoporosis and cancer screening, but I won't get into them. For transgender females, similarly, it's generally every 3-month follow-up in the first year, with follow-up beyond that diminished. Focus on measuring testosterone and estradiol, so suppressing testosterone as well as getting estradiol in a physiologic range comparable to cis women. For the androgen blockade, if someone's on spironolactone, they measure electrolytes. The guidelines don't actually say anything about monitoring kidney function or creatinine, which is interesting, and then also focus on cancer screening and osteoporosis in specific individuals. The complications they highlight, so specifically estrogen increases the risk of venous thromboembolism disease, and there's other risks related to cardiovascular disease, so coronary artery disease, cerebrovascular disease, and lipids. In transgender men, it's really erythrocytosis. There is some potential liver dysfunction, so monitoring liver enzymes is important, and some controversy about safety from a cardiovascular perspective. And the signal from cardiovascular risk, there's different pathways related to estradiol and testosterone that really affect different receptors and vascular function. So there's a lot of different potential mechanisms for why estradiol and testosterone increase cardiovascular risk. And there's been lots of observational studies looking at this. There's been a systematic review about the effects of gender affirming hormone therapy on blood pressure. So this is actually from last year, looking at 14 studies. They were all observational, so pre-post gender affirming hormone therapy initiation without any controls. And only 2 studies were good quality at high risk of bias. So lots of them didn't have power calculations or were underpowered. So only 13,000 patients, about 50% transgender men and women each. Younger, healthier cohorts, not necessarily the types of patients we typically see, and follow-up varied from 4 months to 5 years. Lots of heterogeneity in different types of gender affirming hormone therapy, and very poor reporting about type of blood pressure measurement device, position, stuff like that, and repeated measures. Some mixed results for testosterone. 9 studies showed no difference in systolic blood pressure. And then 10 studies showed no significant change in diastolic blood pressure. They didn't actually perform any meta-analysis due to the heterogeneity in exposure as well as timelines for measurements. For estrogen, a little bit more mixed results. So 3, 4, and 3 showed either a rise or no significant change or a fall in systolic blood pressure, whereas for diastolic pressure, 7 showed no differences. One of the challenges for this one specifically is it really depends what co-intervention estrogen is given with. Specifically, if androgen blockade is by spironolactone or progesterones, that may also decrease blood pressure too. So there's a co-intervention there. So still questions about how much it should affect blood pressure and if you need to intensify therapy in specific individuals. This is a study from Kaiser Permanente in California looking at the risk of gender affirming hormone therapy on venous thromboembolism and cardiovascular risk. This is in the trans feminine cohort. So this is all based on ICD-9, 10 codes, and medication prescriptions. And it showed that it compared to in transgender women versus either men or women as the reference range, that there's an increased risk of VTE and cardiovascular disease with ischemic stroke and myocardial infarction. These are in prevalent users. In incident users, so people that are new starting to estrogen, also increased risk, but there seems to be a time dependency that risk is a higher long term. In the masculine cohort, looking at prevalent and incident users seems to not be as big of a signal for cardiovascular risk in VTE. So this is why the cardiovascular safety of testosterone is a little bit more debatable. So other types of gender affirming care include surgery. So it's a gender affirming surgery is any surgery that a transgender, non-binary, gender diverse individual uses to align their body with their gender identity. So examples of trans feminine surgeries are facial feminization, breast augmentation, orchiectomy, or vaginoplasty. And then for trans masculine procedures, there's top surgeries like mastectomy, and then there's bottom surgeries like hysterectomy or nephrectomy, vaginectomy, medioplasty, or phalloplasty. So guidelines suggest that if you are going to be pursuing this, patients need to be on it gender-affirming hormone therapy for at least 1 year. And one of the common procedures for any type of lower body surgery requires urethral construction, so either lengthening or shortening, and that's required for masculizing or feminizing procedures. There are urethral complications that can happen as a result of this, so strictures, stenosis, fistulas, and there's a risk of urinary retention and obstructive uropathy. It's more common in masculizing versus feminizing surgery, so something to think about as a potential complication that can lead to AKI or CKD in this patient population. Okay, so in the last 10 to 15 minutes, we're going to highlight some of the issues about caring for transgender, non-binary, and gender diverse persons from a nephrology perspective. So there's very few studies about the epidemiology of AKI and CKD in transgender populations. So writing a grant to try to justify this clinical problem has been challenging. This is the most recent and probably only study that's out there that's relevant to answer this question. It's only in 274 individuals. It's from the University of Alabama in the States, and it looked in their electronic medical record and identified patients as being transgender based on ICD-9 10 codes, and looked at exposure to transmasculine or transfeminine gender-affirming hormone therapy and created different categories. So there were 74 transfeminine individuals, 82 transfeminine individuals on gender-affirming hormone therapy, and then 96 and 22 of the transmasculine comparators. They looked at AKI prevalence, and this AKI is using changes in serum creatinine over time, and they found a prevalence of 32%. And then CKD prevalence, which is defined by hematuria, proteinuria, and eGFR less than 60, or any imaging abnormality, was 36%. So 1 in 3, which seems extremely high, but this is based on the nature of their cohort. It was a lot of risk factors. So baseline, lots of hypertension, lots of diabetes, a non-Caucasian population predominantly. They also looked at other outcomes like diabetes and hypertension, didn't show any significant comparison between groups. These are just the comparisons of the figures of AKI between hormones, non-hormones, and actually looked at differences that gender-affirming hormone therapy was actually protective, which is very interesting, but small numbers of patients, single center. So we actually looked at this in Manitoba, looking at Manitoba Center for Health Policy, over 10 years in Manitoba in adults initiating gender-affirming hormone therapy. So we identified transgender persons by looking at ICD-9 and 10 codes for gender-affirming care, and we looked at prescriptions of estrogen and testosterone based on DPIN for more than 3 months per use. And in our cohort, which is about double the previous one I just showed you, about 456 people, evenly split between transgender men and women. The mean age was in the 40s. When we looked at the type of gender-affirming hormone therapy, about half used oral and half used transdermal estrogen for the transgender women cohort, and then about evenly split for oral versus transdermal or intramuscular testosterone. I don't have the other gender-affirming hormone therapy for androgen blockade on this slide. But when you looked at definitions of CKD using EGFR criteria, differences overall in the cohort, 77.5% had CKD, but more common in transgender women versus men. If you look at baseline serum creatinine, there were difference between transgender women versus men here. And then the stages of CKD are shown here. So there are patients out there with advanced CKD, so stage 3B to 3-5 or to 5, even though it's low numbers, these are patients that we do see time to time. And all the questions that I brought up before in the case example, we don't know necessarily what to do. Another thing to highlight too is comorbidities like hypertension and diabetes, as well as vascular disease, are common. And as gender diversity and transgender identity becomes more common, we know that's changing over time. And more than 50% of patients do start gender affirming hormone therapy. These numbers are only going to increase over time. So we need to start addressing some of these questions. One of the challenges is the representation of transgender and gender diverse and non-binary individuals in research is lacking. If we think it's 0.5% of the population or even higher for gender diverse individuals, at least in nephrology, this is specifically in dialysis trials what we looked at. So they're not even reported, which is a problem. So we looked at 561 trials from top medical nephrology, cardiovascular, and general medical journals that had any type of randomized controlled trial in the setting of dialysis. So we collected a whole bunch of factors here related to trial design and the intervention and outcomes and funding to look to see what was the proportion of men or women. So we found that it was about 40% women overall, and that the only factor that was a significant predictor of trial design was country. Basically, Asia trials had higher prevalence of female or women participants. But out of all those trials, and only 542 of them actually reported the proportion of female and women, so that's about 40% here. When you looked at the nomenclature and descriptor, when people were using sex, gender, or both, there was very poor reporting about what actually people meant, and then not a single study reported a transgender, gender diverse, or non-binary participant. So the question is, how inclusive are we being from a research perspective? Does it matter? Will it affect recruitment and representation and generalizability in such a small patient population? And then how do you actually incorporate sex and gender into analysis plans and stuff like that? And cardiology and other chronic diseases have been ahead of the game for this. So this is something that we're exploring a little bit across academic research organizations like PHRI and the George, et cetera. So some considerations about gender affirming hormone therapy in the setting of CKD. With the hypogonadic hypogonadism, you don't actually know if the doses needed for developing secondary sex characteristics are higher or lower, probably lower in CKD and dialysis in the general population, but at least we know that sex hormone binding globulin levels are altered in CKD. So if you're going to follow testosterone levels, you have to do a bioavailable or free testosterone levels. There's a lot of controversy about the safety of testosterone from a cardiovascular and prostate related event. And with that risk of erythrocytosis, especially in the setting of concomitant iron use or erythropoietin stimulating agents, it really needs to be carefully monitored. For estrogen and androgen blockade in the setting of kidney disease, the pharmacokinetics of estrogens do differ in cisgender females in CKD dialysis, and there's studies about this. So estradiol and estrone are not significantly excreted in the urine, and neither is dialyzed, but the free and total estradiol plasma concentrations are higher, and that's related to the sex hormone binding globulin. So typically 50% dose reduction. We know that patients with CKD on dialysis have higher risks of VTE and cardiovascular risk related to declines in EGFR, proteinuria, as well as comorbidities. So there's a recommendation to potentially use transdermal estrogen, which might have lower risk. Also realizing that surgery, hospitalizations, and mobilizations can increase the risk, especially during kidney transplantation, but there's controversy about what to do at that time, and even evidence from the general population that it actually might be safe to continue hormone replacement therapy in cis women from estrogen and not increase the risk of VT in that patient population. Be careful about spironolactone dosing, especially in advanced CKD with the risk of hyperkalemia. Other types of androgen blockades do not need to be dose adjusted. So when you look at the effects of gender-affirming hormone therapy on body composition, there's a couple of systematic reviews about this. This one's from Claver in 2017, and it shows the change in body weight, body fat, and lean body mass in both transgender men and women. For transgender men, their lean body mass increases, and this is 3.87 kilograms with a 95% confidence interval between 3 and 4.5 around, with a decrease in body fat and an increase in body weight, because gain more muscle than loss of body fat. So body composition does change, and creatinine should change. In transgender women, some opposite direction, loss of lean muscle mass, but gain in body fat and increase in body weight. So the question is, how does that actually affect creatinine or cystatin C or proteinuria or GFR? So we actually did a systematic review, and this right now is submitted for publication. Hopefully will be accepted soon. So we looked at all cohort and RCTs of gender-affirming hormone therapy on kidney function outcomes, focused on the ones I just mentioned. So we found 2 RCTs and 11 prospective studies that looked at pre-post measurement of gender-affirming hormone therapy on kidney function, most from the US and Europe. And there's a lot of heterogeneity in, again, designs, the type of gender-affirming hormone therapy, different populations. Typically younger and healthier without any evidence of CKD at baseline, because it's generally an exclusion criteria for these types of studies. We found that 21 reported serum creatinine, 7 reported blood urea nitrogen, not a single study reported cystatin C, and only 1 to 3 studies reported other outcomes related to eGFR or creatinine clearance. And we didn't find anything about albuminuria, proteinuria, measured GFR, or eGFR performance in a study. So we were able to do meta-analysis looking at different time points. So we took 3, 6, 12 months as short-term, middle, and long-term changes in serum creatinine and stratified in transgender men and women. And what we found in random effects models with repeated measurements, that serum creatinine went up in transgender men as soon as 3 months, as well as by 12 months, by around 10 to 12. In transgender women, we found that serum creatinine actually decreased anywhere between 5 to 6, and that was apparent across the 3, 6, 12 months. So when you're taking care of a patient that starts gender-affirming hormone therapy, these are expected changes. And sometimes this can cause concern that there's progression of CKD or a diagnosis of AKI, depending on what a baseline is, stuff like that. So something to be aware of. So some considerations about estimating GFR in this patient population. eGFR equation, so MDRD, CKD, EPI, so the 2009, 2012, and 2021 race agnostic equation. They're developed and externally validated in cohorts that use cisgender individuals. So the whole premise behind it is that creatinine and cystatin C vary by sex/gender, either from a biological perspective or from a gender perspective related to behaviors and muscle mass. Other non-GFR determinants include age, previously race. So those are covariates in linear regression models that have their own coefficients. So the thought is that creatinine and cystatin C vary by cisgender males based on changes in lean body mass and muscle mass and nucleated cells, specifically for cystatin C. They're not perfect markers of GFR because, you know, there's tubular secretion, there's non-GFR determinants like diet, other things like that, but it's the best that we have. So why do we need accurate and precise measures of GFR on a population and individual level? So if you have some degree of uncertainty in your eGFR in your patient population that there might be systematic bias. So whether it's previously race or now gender diverse populations, there's a lot of issues that can happen. There can be misdiagnosis of CKD. There can be early or too late referrals to nephrology, can affect the prognosis, determining response to therapy if you're using induction or maintenance therapy for GNs, eligibility for medications. I actually got an email from a patient when I published our CGKHD review on this topic saying that they had been excluded from a Vaptan trial and follow-up because of the gender-affirming hormone therapy and changes in GFR. And this was 10 years ago. And they were very happy to see raising some light on this topic and actually shared our paper with their nephrologist, which I thought was really cool. It can affect medication dosing, access to imaging, so whether it's contrast or gadolinium, vascular access planning, kidney transplant referral. Another story about this one, I'm on a guideline committee with American Association of Clinical Chemists and National Kidney Foundation about this specific question. And there's a patient partner who actually published a paper with Dina Green, who's a biochemist in the States, about their experience with CKD and having a late referral for transplant because of all the issues about what EGFR in the EMR was actually used to trigger decision-making, and really struggling with being advocacy to get the right type of care. And then dialysis initiation eligibility criteria. So a lot of problems that could come with not having an accurate or precise measure of GFR. So if you look at the New England papers for CKD Epi in 2012, as I mentioned before, it's all about sex here. They don't report any transgender patient populations in any of these cohorts. If you look at the coefficients here for male or female, there's different combinations for serum creatinine, cystatin C. This is the 2021 updated one, same thing here, that in the cohort of over 8,000 patients, it's really just binary male or female sex without any consideration of gender or gender diverse populations. And these just show all the coefficients here for female sex across the different categories. So if you look at the potential systematic error of using the wrong sex or gender in your CKD Epi creatinine equation or cystatin equation here, it's higher at higher GFRs and serum creatinines if you just put in like a binary male or female. And this is just shows the differences in errors across different age, so 20, 40, 60, 80. So lower, probably less of a problem at lower eGFRs and higher serum creatinines, but lots of variability at higher eGFRs and lower serum creatinines. Just a quick shout out to albumin to creatinine ratio and protein creatinine ratios. So we typically use these because the 24-hour urines are burdensome, costly, and impractical. So they're used to estimate 24-hour urines, as well as for staging, diagnosing CKD, prognosis, so kidney failure risk equation, and then determining response to therapy. We know sex and gender can affect serum creatinine and urine creatinine excretion. So if you're trying to extrapolate and there's different conversion factors to estimate 24-hour urine, same thing in a transgender, gender diverse individual, how do you correct or estimate? So we don't actually know how to do that. And in the systematic review, we didn't find anything about proteinuria in these patient populations. So we don't actually know what the best way to proceed is. In the kidney failure risk equation, it also has a binary input for sex. It uses male versus female sex. Interesting, the other factors involved, so eGFR and ACR could be influenced by sex and gender as well, potentially. So in the development and validation cohort from Dr. Tangri's paper from JAMA, it is only looking at sex, so male versus female. So same questions about what is the input, how do you adjust? We don't know. So what do we do if we don't have all the information right now? So I think first step is acknowledging that there is a lack of precision accuracy in any EGFR equation or ACR PCR interpretation in a transgender, gender diverse, or non-binary individual. And we should disclose that and have it involved in shared decision making. If you have someone on gender affirming hormone therapy using both inputs for sex, so male, female, and showing a range of possibilities and looking at the muscle mass of the individual in front of you to try to tailor or guesstimate which way their physiology aligns with their muscle mass, I think is a reasonable approach. If someone is not on gender affirming hormone therapy, or they've stopped it for a prolonged period of time, whether that's 6 months, 12 months, 18 months, using sex assigned at birth rather than gender identity is a reasonable approach if it aligns with the muscle mass that you're seeing in front of you. But ultimately, if it's a critical decision, so if it's a medication with a narrow therapeutic index, if it's about referral to transplant or other things like that, using a measured GFR or a 24-hour proteinuria would be certainly a safe choice. Cystatin C as an option, we don't know what are sex references or gender references in these patient populations, which is work needs to be done. So we have a couple of review articles about this topic now. This is one that's about to come out where we highlight a lot of the questions that I've gone over and kind of plans to tackle this in the next 5 to 10 years that people are working on, including myself. So big questions about how do you estimate GFR? Does gender affirming hormone therapy change measured GFR? Does it just change GFR biomarkers? Does it affect proteinuria? How safe is gender affirming hormone therapy with the interactions between CKD, so decreased eGFR and proteinuria from a VTE and CV risk, and even other things like volume of distribution for KT over V calculations, et cetera, in dialysis populations. So we're trying to actively investigate this. I have a CHR grant out right now that looks about the impact of gender affirming hormone therapy on kidney function. We're trying to recruit in 10 centers. You're looking at 72 patients, half trans men and half trans women, about a quarter with CKD target recruitment, looking at 0, 3, 6, 12 months effects on measured GFR by iohexol, as well as proteinuria, cystatin C, creatinine, et cetera, knowing the gaps in the literature. So hopefully in the next couple of years, we'll have some more answers about this. I'll skip over that. So I just want to thank a lot of people that have been involved in this work so far. So that includes nephrologists, including Adira and Monica locally, endocrinologists, so Marshall Dahl from Vancouver has also been involved in some of this work, family physicians, there's gender confirming surgeons that are part of the team, biochemists and biostatisticians, and then importantly, patient partners and transgender, gender diverse organizations from across Canada that have been supporting this work, including Transcare BC. So I'll stop there and open it up for questions. Thanks so much.
Thanks very much, David, and thanks for bringing this so to the fore. There is a question in the chat. Are there any on nuclear unigram GFRs compared to eGFR for trans persons with CKD pre and post gender affirming hormone therapy?
So there is not. So the all intersystematic review, it was all focused on kidney biomarkers, specifically creatinine. So no one has done any measured GFR in this patient population, which is what we're focus of our study. There is a group, they're called ENIGI. It's a 4-country from Europe that has led research in transgender organizations or in transgender and gender affirming hormone therapy that are actively doing a study, but it's 25 patients. And I think they're using DPTA and not, the question is like, what is the gold standard for measured GFR? We're going to use iohexol clearance, but no one has done this yet. So we don't know if it's actually, is it GFR that's changing as a result of sex hormone changes, or is it changes in body composition, muscle mass, and the biomarkers? So we don't know the answer to that.
But I guess, I mean, to go back to what you said, if you're not sure what someone's GFR is, whether, no matter what, you would always measure. And I think we sometimes forget as nephrologists that it's always an estimate. And if you need accurate, you need to measure no matter what their gender, size or otherwise, right? So I think that is an important message outside of a study perspective. But I think it is curious to think about how I hadn't actually appreciated or thought a lot about how we might change our drug dosing based on that we would be interpreting things wrong and potentially dosing drugs wrongly in people. So I think that's also a really important lesson. Other questions from the audience? You're welcome to raise your hand if that's easier than typing something.
And Adira, just to your point, like for the case presentation that I showed, it specifically has the, like this is a typical patient you might be referred in clinic, and it has the changes in the creatinine based on our systematic review and changes in eGFR with it. And like a change in GFR of 10 from 40 to 30 based on the incorrect use, that's pretty significant. And you can imagine if it was between, a little bit lower, some 35 to 25, that might make people say, the SGLT2 inhibitor for like, whether it's DAPA or empagliflozin or whatever, it hasn't been studied below that GFR. We're not going to offer this to you. So these are actually really relevant, depending on where your GFR is and the decision made, as well as like the pre-post measurements of change in your GFR of dropping by 4 to 5. That's, in a 1 month, that could define someone who's rapid progressing, that might trigger additional investigations, when it might actually just be changes in muscle mass and kidney function biomarkers independent of GFR. So
yeah, I think, no, you're right. And I think the other thing that's very interesting is the underdiagnosis of AKI in women that might actually, signal us to miss important points along a trajectory in a female. So I think there's a lot here for all of us to reflect on, just the spectrum and the differences in sex, either at birth or subsequent, that actually should really help us with this whole precision medicine notion in nephrology, right? That it's not a one size fits all, and these nuances are very important. So we are at the bottom of the hour, depending on which province you're in or place you are. Thank you very much for a very thoughtful talk. I think there'll be lots of questions, and anything we can do to help in contributing to data. As you know, we're always very willing and able and happy to do so. So thank you again for all that you're doing, all the questions that you're asking and helping to answer.
Thanks so much. Thanks for having me in. Take care, everyone.
Yep.